Now that we've talked about some of the blood types and other tests that we're going to do at that first prenatal appointment, let's talk about the potential impact of some infections in pregnancy. HIV would obviously be a large issue. The fastest growing population of HIV is women. Women are more susceptible to HIV than men are, so unfortunately that seems to be the growing issue right now. If we can identify that our mother is HIV positive very early in the pregnancy, we potentially still have a very good outcome for that fetus, which is very important to both her mom, her family, and her baby. It is possible for the fetus to contract HIV transplacentally, meaning it goes through the placenta, it can get to the baby. Also, it can be transmitted through breast milk, so absolutely no breastfeeding for any mom who is HIV positive. If we do identify it early in the pregnancy and we can treat mom throughout that pregnancy with AZT, they're obviously going to watch her blood work very carefully. When she goes into labor, we are going to give that patient IV AZT during the labor process so that we can expose the fetus to it as well. As soon as our newborn is born, they are treated with oral AZT within 8 hours from birth. If we can do a continuous course of treatment, even though these babies may be born HIV positive, those antibody tests will usually convert to negative before the baby is 18 months of age, and the baby will be HIV negative. This relies on screening and treatment. The patient who is HIV positive is obviously going to need some slightly different nursing care once especially they hit that labor process. When we talked about fetal heart rate monitoring, remember what we used for internal fetal heart rate monitoring. An fetal scalp electrode, or FSE, that normally would be attached to the baby's head increases the risk for blood transfusion index, so that's off the table. IUPCs, intrauterine pressure catheters, we're not going to use. If the baby is in an intact membrane, meaning we have not broken her water, or her water hasn't broken on its own, we're not going to break her water because we want to keep that protection there as long as possible. If it breaks spontaneously, we can't control that, but we're not going to increase the risk to the baby by doing it ourselves. Another difference in this nursing care is that most babies are not bathed until 8 to 12 hours after delivery due to concerns about their temperature. This baby, we are going to bathe as soon as possible. We're going to keep that baby in a nice warm place, but we want to get all of those body fluids, vernix, everything off the baby as much as possible. When we do those first newborn injections, immunization, vitamin K, we're going to be very, very sure we use lots of alcohol and get those sites clean. If our baby needs blood sugars, again, we're going to delay those until after we make sure that skin is clean. Medical personnel in this delivery should obviously be very, very cautious with their universal precautions, but we are going to be extra cautious here, probably wear masks and double glove and gowns. A normal birth, not everybody normally wears gowns and masks. The delivering practitioner will be gowned up, usually will have a mask on, but in general the other personnel in the room does not. The patient with HIV, other personnel in the room are going to be gowned up, masked and gloved as well. Torch infections, as mentioned before, are a specific group of infections that can go through the placenta. Perinatal infections account for 2 to 3% of all congenital anomalies. The infected newborn can show abnormal growth. They can show developmental anomalies, or they can have clinical and lab abnormalities. Infection, not a good thing. We want to treat it every chance we can, which means we need to know what's there. Torch infections, well, I should say TORCH was created as an acronym to help us remember these particular infections mean that the fetus is more susceptible to them. T is for toxoplasmosis, which is really unusual, but it can be found most commonly in cat feces. This is why pregnant women are told they do not ever change cat litter. We also want them to be cautious in gardening and working with soil that cats may have gone to the bathroom in. Bird poop can have toxoplasmosis as well, as can undercooked meat. The fetus is very susceptible to this, so we want to make sure if it's there, we can catch and treat. Don't you love acronyms that include something like other? That's, not terribly helpful. Sorry, I don't have a handy dandy study trick there for you. You just got to remember that other infections that can cross the placenta include gonorrhea, syphilis, varicella, also known as chickenpox, hepatitis B, the group beta strep bacteria, and obviously HIV. The rest of our acronym is to help us remember that rubella, the cytomegalovirus, and herpes belong to this group of infections as well. Torch infections are a problem for both mother and baby. They can all cross the placenta. Torch infections increase her chance of premature labor. The most common cause of premature rupture of membrane is infection. Prenatal screening is crucial because sometimes our mother doesn't have any obvious symptoms. Sometimes we will catch a torch infection because throughout ultrasound tracking, we realize our baby isn't growing the way it should. So we may draw a torch panel just to rule that out. One of the most common complications is caused by the group B strep bacteria. Group B strep is a little bit unique. We're going to talk specifically about that here in just a few minutes, but we would do a test for that as well. Again, torch-related complications, heart defects, anomalies. Congenital simply means it can be defined as a structural or functional anomaly that occurs during intrauterine life. So as they're developing, that would be when they potentially are diagnosed with congenital heart defects or anomalies. The first trimester is the point when that fetus is developing basic structures and symptoms. So any infection happening in the first trimester has more risk of impact on the development of that fetus. Intrauterine growth restriction. Usually you're going to see the initials IUGR. That's what they're referring to. Mean our baby is not growing at a normal rate inside the uterus. Torch-related complications can also cause developmental and mental disabilities, can cause infection and swelling in the brain, and hydrocephalus. Group B strep infection. The Group B strep bacteria is present in anywhere from 20 to 30% of our population at any time. It comes, it goes, it comes, it goes. Our systems have adapted to this as we've gotten older. It can cause problems for an adult, but it's much less common. A newborn has never been exposed to this particular bacteria, nor has a fetus. So if in some way, shape, or form, such as throughout the birth process, a newborn is exposed to a Group B strep bacteria, that baby is at a significantly higher risk to develop sepsis and other infections. And as soon as we recognize this, we realize that there's a way to significantly decrease the risk to these moms and babies. If a woman is GBS positive, when she comes into labor and her cervix is starting to change, we're going to give her IV antibiotics, most commonly penicillin. Generally, penicillin is given every 4 hours until she delivers. So if she delivers in 12 hours, she's going to get 3 doses of penicillin. In order for the penicillin to completely clear out the Group beta strep bacteria from her body, it needs to be administered 4 hours prior to birth. If we give her a dose of penicillin and she delivers 2 hours later, well, we might have gotten some good out of it, but we can't say that we cleared out that bacteria, so we're going to have to watch that baby a little bit more closely. Generally, women are screened at about 35 to 37 weeks gestation. The screening is simply a long swab that is run over the vaginal and rectal area, sent off to the lab. It comes back and tells us if she's positive or negative. This, again, can come and go. Maybe it's there at the beginning of the pregnancy. It might not be there towards the end of the pregnancy, or vice versa. In addition to screening for infections, the sad fact is we need to be screening for domestic violence as well. This is something that should start at that first prenatal appointment and continue with every encounter with the medical system throughout her pregnancy. Keep in mind that domestic violence is related to a lack of control or power on the partner. The sad population fact is that pregnant women are more likely to be abused than the general population. People usually assume someone who is pregnant is less likely to be hit, but unfortunately it's the other way around. Pregnancy presents a big challenge to a relationship, and a partner has very little control over how this pregnancy is going to happen. Thus, even in women who may not have had that issue prior to pregnancy may suddenly recognize that they're dealing with an abusive situation. The more often we ask if she is safe at home, the more likely she is to reach out for help. This is why we ask every patient every time some version of the "Are you safe at home? Do you feel safe in this relationship?" Different facilities are going to have different scripts or phrasing they would like you to use. The important thing is that we're asking every single time. The web resources below are both great things for you to have handy in your head, both for your professional and personal and family work life. The domestic violence website, the hotline.org, has lots of good resources. Futures Without Violence is specifically directed to healthcare workers. That's a really interesting website to investigate as well. In addition to domestic violence, we are also screening for substance abuse. Remember, substance abuse consists of lots of different things. We have alcohol, tobacco, even though they're legal. They are not a good thing to be doing when you're pregnant. Education is crucial for our patients to understand so they recognize the consequences of the decisions that they make. Marijuana, cocaine, amphetamines, heroin is unfortunately increasing. Well, increased use of heroin over the last 5 years has been tremendous. I have seen a big difference in nurseries. There are more and more babies who are having to withdraw from heroin, from amphetamines, and from other prescribed or illicit drugs. The opioid crisis has made a big impact in pregnancy and nurseries as well. The biggest risk factor for substance abuse is age. This graph is the percentage of pregnant women. Over here, the different colors are showing us different age groups. So 22% of pregnant patients between the age of 15 and 17 are using illicit substances. Here, we're counting everything: cigarettes, alcohol. Then they're broken down a little bit more specifically. You can see that there's a big difference between the age of 15 to 17 and the age of 26 to 44. However, it's interesting to me that those differences change at different ages as well, depending on when it's socially acceptable or not. What does the nurse do if she suspects or he suspects the patient is a drug user? Different facilities and different cultures at different facilities are going to impact how this is done. In general, if the nurse sees risk factors, such as a lack of prenatal care when the patient enters, then the nurse will collect a urine drug screen. At some facilities, you would get the patient's permission for this. At other facilities, that doesn't seem to be addressed. So keep an eye out, tell me what you see in clinical. A urine drug screen is sent. If it comes back positive, you must notify social services and they will come and talk to the patient. Now, in some scenarios, you might have a conversation with the patient about that positive drug screen, and others, social services you might not bring it up until social services gets there to initiate it. As we all know, a urine drug screen is not always terribly accurate. The time periods vary depending on what kind of substances they're using. However, in obstetrics, we have another method that is much more accurate. If there is any potential suspicion of drug use, we are also going to get the infant's first meconium, their first poop. Meconium is the stool inside of a fetus. When they are born, they start swallowing and eating. That meconium passes through the digestive system and they have their first black, tarry, sticky poop. That meconium has been in the fetus's system for quite a while. So if the mother has been doing any kind of substance abuse, specifically illegal drugs, A meconium screen can pick that up and be accurate for up to 2 or 3 months. Again, we have to collect the first meconium screen in order for us to make this the most accurate. So the nurse, usually in this scenario, the postpartum nurse needs to be aware of that. Again, social services is going to be involved. CPS involvement is mandatory. However, be aware that just because she has a positive UDS or a positive meconium drug screen does not mean that she will lose custody of that baby. Social services has a lot of variety in how they treat patients. Do not make any assumptions about what will happen. Let social services have that conversation with the mother. If you have an obstetrical patient who is on methadone or is addicted to heroin, you need to be very cautious with your use of Narcan. When you give Narcan to a pregnant woman, it travels to her fetus as well. Now, you may think this is a good thing, right? Get rid of that. The problem is sudden and abrupt withdrawal of a fetus is very likely to cause fetal seizures and permanent brain damage. So Narcan is something that needs to be used cautiously in obstetrics. Babies who have been exposed within the womb are diagnosed with neonatal abstinence syndrome, also called NAS. These babies generally present very, very rigid. They are hyperactive, their tone is very tight, they have a very persistent shrill cry. While babies the first 2 hours after birth tend to sneeze a lot and have hiccups, that should go away. At 24 hours, if your baby is continuing to sneeze, that could be a potential sign of withdrawal. Again, the opioid epidemic has significantly impacted this. The statistics are that every 25 minutes, a baby is born who's suffering from opioid withdrawal. They treat these babies by prescribing a drug similar to the one the mother used during pregnancy, and then slowly controlling and decreasing that dose over time. This helps wean the baby off the drug. These babies are frequently admitted to the hospital nurseries for up to 4 to 6 to 8 weeks after birth, depending on the scenario. Tobacco impacts the baby's growth. Obviously, other illicit drugs that we use, you can see, have problems both during the pregnancy itself as well as withdrawal afterwards. Alcohol impacts pregnancy and the fetus in a very different way. Alcohol is a teratogen. That means it is poisonous to the fetus. We as adults process alcohol through our livers. A fetus does not process things through a liver. That fetal circulation bypasses it, which means that the alcohol is potentially, or the fetus is being exposed to alcohol at different points throughout that circulation process, which means they're a lot more susceptible to damage from alcohol. The baby who is born with some type of fetal alcohol spectrum disorder will sometimes have very distinct physical characteristics. This is a picture of a sweet little baby with some severe fetal alcohol spectrum characteristics. You can see they have smaller eyes, a smooth philtrum, that's the little space, that line from your nose to your lip. That upper lip is frequently very, very thin as well. Sometimes you will be able to see this baby right after they're born and recognize that alcohol has been a problem in this pregnancy. Other times, things might not show up until the baby gets older. Physical symptoms include a small head. They include a fetus that does not grow at the appropriate rate, which carries over into the newborn period as well. Nursing interventions for these babies. These babies, unlike the NAS babies that are very shrill and rigid with firm tone, may not present that way, but they generally have developmental issues. They cannot react to stress well. So the best thing a nurse can do with a fetal alcohol spectrum disorder infant is to decrease the environmental stimuli. They need to be in a quiet corner. They need to keep it dark. Often they are not coordinated enough to suck and swallow, so we may have to put a little tube down their throat into their stomach and feed them that way for a while. Long-term implications are a problem of this in our society. During the pregnancy itself, you can have congenital abnormalities. We know that there is cognitive dysfunction in fetuses that are exposed to alcohol that may not be recognized until they get older as they develop. Frequently, they have poor coordination. Cardiac and joint abnormalities are common. Another problem for these children is that they tend to have very poor impulse control and judgment. So they don't make great choices, and you can see they have lots of physical challenges in addition to that. This family needs a lot of support. They are going to need resources. They are going to need to find ways that they can give this child the best outcome that they can. Education about domestic violence, about use of alcohol, tobacco is going to continue throughout the pregnancy at every appointment, but that first prenatal appointment is where we can first talk about these issues and potentially make a big impact. After her first prenatal appointment, 4 weeks later, assuming we don't have any other risk factors, she's going to come back, and her next appointment will not take as much time. From that point on, routine prenatal care includes a blood pressure. If there were abnormalities on her original CBC, we might repeat that, but if there were not, we probably won't. She's going to be weighed. We're going to look at her abdomen. We're going to assess a fetal heart rate, frequently with a little Doppler, and we are going to palpate her abdomen and assess fetal position. Each follow-up visit, we should have time to answer questions, to provide anticipatory guidance and education. We need to review nutritional guidelines. You need to ask her about taking prenatal vitamins and diet. Throughout the pregnancy, we want to encourage the woman's partner to participate as much as possible as well, because that's only going to impact her for the good. This is a great picture of part of that abdominal exam. It's going to include measuring her fundal height. Remember, the fundus is that groove of muscular tissue at the very top of the uterus. When you palpate the mother's abdomen, you can kind of feel for the top edge of that uterus. To measure a fundal height, you're going to go from the tip of her pelvic bone right across to the top of that uterus. The good news is that fundal height will coordinate with the gestational age, starting at about 14 to 16 weeks. Once she hits 20 weeks of pregnancy, her fundal height should be 20 centimeters. So that's a nice low-tech way for us to keep track of fetal growth throughout the pregnancy. That works until about 36 weeks. You can see the tip of this uterus growing. There's the fundus, 28 weeks, 32 weeks. About 36 weeks, a process happens that we call lightening. That just means that things shift, hormones make some of the ligaments in the pelvis relax, and her baby will drop. You may have heard that term as well, meaning the uterus kind of settles a little bit lower into her pelvis. So now our fundal height, because the uterus has moved lower, will decrease instead of increase. So not uncommon to get a fundal height of 36 centimeters at 36 weeks. And if she goes back at 37 and 38 weeks, maybe that fundal height doesn't increase or it actually decreases. Most of the time it's because she's dropped, not because the baby's not growing.